In this video, I'm going to be covering the clinical presentations of shoulder impingement as well as manual-based conservative treatment of it. What's up, everybody? For those of you that don't know me, my name is Dr. Matt Maggio. I am the creator of the 𝘗EHC method and founder of the soft tissue revolution, where we teach manual therapists a new treatment system that does focus on working smarter, not harder, allowing them to cut their treatment times by 50% so they can stay healthy and help a heck of a lot more people get out of pain. Shoulder impingement. Shoulder impingement. Shoulder impingement is what I call an incomplete diagnosis. A big thing that I always teach and strive to share with everyone out there is getting to a tissue-specific diagnosis or problem list. A lot of manual therapists, specifically massage therapists, come to me and they're like, well, I'm not allowed to diagnose in my scope of practice, so I can't do that anyway. I'm like, well, that's bullshit. You got to know what's going on. Just because you can't legally diagnose, you still have to know what the problem is. And the problem with shoulder impingement is it doesn't really tell us anything. It basically just says something's getting stuck and jammed in there. There could be a million different things going on. And then you're just doing a bunch of random treatment, never really know what's going on, never getting to the root cause, and then you can't fix a problem. And they wonder why the medical system's so jacked up and not working correctly, because nobody's getting to the root cause of what's going on. How in the hell can you fix a problem if you do not know what is going on in the first place? So what's more likely going on here? There's going to be two things that I see a lot in my own clinic. One's going to be what's called a labrum tear. The labrum is actually the cartilage of the shoulder. It also has a fancy name called a slap tear as well, and that shows up on an MRI. So a couple clinical signs of a labrum tear. One is it's going to be very sharp, very stabbing, lots of popping, lots of clicking. A big thing that I always talk about is you have to take a thorough and in-depth history every single time before you ever jump into treatment. So there's a lot of things that we go through. I cover these in my free training modules about the idea of asking the right questions and then forming that tissue-specific list. But yeah, labrum's going to be very sharp, very stabbing, popping, clicking. Another thing that I see in the history of a labrum problem is more pain when they're using it, especially reaching for things, maybe reaching up in a shelf to get something down, putting their seatbelt on. I see this sometimes in women, reaching around and unstrapping their bra, or just getting dressed, pulling a shirt overhead. That can cause a lot of issues in there as well. Another thing that I look at is how high are the pain levels, specifically with the use of it, and then they're not as bad when it's kind of stable, not doing a lot of things. So the way I look at pain is I grade it for the client. I say on a scale of 0 to 10, 0 no pain, 10 you wouldn't care if we just cut the area off, what's the worst it's gotten. And a lot of times when I see a labrum problem, it gets that 7 or 8 or 9 if they reach just in a weird position, or they try to put their seatbelt on. They might be like, ooh, it grabbed on me and it's really sharp. But a lot of times when it's just the shoulder's just kind of hanging there, it doesn't really hurt that much. It stays a little bit lower in there. Another thing that I see is when they lay on it, it really can cause some problems, especially if they fall asleep on it, or they lay on it, they wake up and everything just feels really stiff and not moving. A big thing I'm going to be looking for in the history of a labrum problem is going to be a history of trauma, specifically a dislocation or a separation. The cartilage is pretty resilient and can handle a lot, but if there's a lot of trauma in there, accidents, falls, and especially in athletes, especially those that played football, baseball, and hockey, where they're really putting a lot of force and drive in there. And I tend to see this a lot more in a younger person, because the cartilage is more susceptible as you have more space in the shoulder. As you get older, the cartilage kind of tightens up and doesn't really get torn as much as it does when you're younger. And you see these problems earlier in life, not as much later in life in there. So that's what I end up seeing for a labrum. And then a test that I do, and I go over a lot of these in my free training modules, but I do a test called shoulder abduction. And basically the idea for shoulder abduction is we just see how easily their arm can come up, and we want to see that their bicep can easily touch their ear. I start with shoulder abduction first, as opposed to the other motions of the shoulder, internal or external rotation. I really don't give a crap about their internal or external rotation. If they don't have good global motion first, that's what we need to restore. So a lot of times when there's a labrum problem, they'll usually bring it up and then they'll be like, ooh, that doesn't feel good. And then they work through it and it doesn't feel bad again. And then as they bring it back down, it gets caught again. And then that gives that problem in there as well. What's happening is somewhere in there, there's a tear of that labrum and it's getting stuck into the joint as it goes up and it gives them that painful arc. The next issue that I end up seeing here is what's called degeneration to the supraspinatus tendon. You know, degeneration is just a general term that things wear out before their time, and a lot of times the tendons end up having a problem. So a quick note on this idea, and I talk about this a lot, the idea of tendinitis versus tendinosis. I've covered this a lot in depth in more videos, but everyone gets diagnosed with tendinitis. Tendinitis is another one of those what I call junk box diagnoses. Doesn't actually tell us what's going on. What's really happening in there a lot is there's actually degeneration to the tendon. Over time, when the muscles don't move how they should, they put more pressure on the tendon. As the tendon gets more pressure in there, it actually gets bigger and bigger, but it's not good quality, and eventually that starts to tear. So a lot of these problems in the tendon are actually a tendinosis, not a tendinitis. Tendinitis is just a junk box diagnosis. Tendinosis is actually a bigger problem, and a lot of times that tendon gets beat up more and more, and this is when people get that supraspinatus partial tear or even some degeneration in there. So a couple of clinical signs if it's going to be more of like a tendon problem, specifically for the supra. Number one is going to be symptom location for sure. It attaches on the front anterior part of the shoulder there. And a lot of times they'll be able to pinpoint there and say, yeah, it hurts right in through there. That'll really give you an idea that that's more of a tendon problem. It's definitely going to be more common in an older person because tendinosis doesn't just happen overnight. It takes time to build up and years to kind of build up. You know, you're going to see this more in like a 40, 50, 60-year-old. Not going to see as much of that tendon degeneration in a younger population. Another thing I'm going to see is there's going to be, the pain levels are going to stay a little bit higher throughout the day, but they won't spike as much as that labrum does. And it really stays more in that like 3 to 7 range. So like the labrum, when you actually use it, oh man, that hurts like hell. Where if it's a supraspinatus degeneration, it just kind of always feels a little bit achy. And then if you move just right, it can jam it up. But it's never like that sharp stabbing, like, oh my God, this is awful. But it's more uncomfortable and really always there. And then another thing that I end up seeing is it always just kind of feels worse when they're like approaching 90 degrees. Like maybe they're like, they get to here and they go, ooh, that tendon's getting jammed up in there, or reaching for something. And they will get some pain when they lie on it as well, but nothing as bad as like the labrum. When the labrum's bad, they can't move at all. Everything locks down. Usually with the supra problem, they can get to a certain point and then it kind of stops and then they don't want to go any further with that. With the labrum, they can get there and then they work through it. Supra, they just really they stop really quick and can't go any further from there as well. And here's a quick note on why rotator cuff surgery is bad and ineffective. The question I'm always asking is, was there trauma or not trauma? So when I have a client that comes in and they don't have any direct trauma, but they have partial tears of that tendon, of that supraspinatus, I'm thinking there's a problem somewhere else. So what happens is they go to the ortho, and the ortho's like, oh, we did an MRI. Look, you got some degeneration in the tendon. We'll go in there and sew it up, but there's no trauma. What happened is that area is getting overloaded because other things aren't working correctly. I always say that is the effect, not the cause. I always say also that tendon is kind of like their thumb stuck inside a car door. The car door is all the other muscles around there that aren't functioning correctly. They're loaded up with scar tissue. Scar tissue makes the muscles weaker, less flexible. And what happens is you can't give that tendon a chance to heal up till you remove the door. When they just do the surgery, it's like they pulled the thumb out, but then a couple days later, door jams right in there again. Not any better. Surgeon still gets paid, doesn't help anybody, problems get worse. And you see this more and more in the older population. They're like, I got a rotator cuff tear, I need to have surgery. They end up doing a hell of a lot worse, specifically if there wasn't trauma involved in that injury presentation. So that's a big question. Like, did you have trauma or not? No trauma, probably better off being treated by me instead of jumping into surgery, because it's just going to make things worse. So now that I have an idea of what's going on, is it a labrum problem? Is it a cartilage problem? Where the scar tissue is? Now I have to get in there and manage these cases. I really like these cases. I like a little bit more complex cases where things have been going on for a long time. They've seen multiple providers, haven't got any better. I like to be the last person that comes in instead of the first person. So first, what I like to do is I need to manage the load, especially if I have a labrum problem. And if they're a younger athlete, they want to do a ton of stuff, but what's going on is what they're doing is actually causing bigger problems. So I like to use a lot of analogies there. I always tell these people, it's like, kind of think of like, I'm the dentist and I'm going to go in and do like a deep drill and get that cavity out of there. And as long as you're good in between of not doing too much, that's like not brushing and flossing your teeth. But if you do too much of that, you're going to get more cavities as we go. I really like dental analogies. They really help explain what's going on and the client can understand it as well. Next step is I need to restore that shoulder abduction like we talked about. I got to get that global motion first. Like I don't give a shit about internal, external rotation until I can get this motion first. And I have to get that back as well. There's an order of operations to fixing any problem. First step is we have to get range of motion back. If we start to strengthen it or stretch it or do anything like that, that's kind of like putting a roof on a house before we ever lay down the foundation. So there's 3 areas that I focus on in my treatment process that are very involved in that shoulder abduction. First one is going to be the �㫭𝑠𝑝𝑖𝑛𝑎tus. Next is going to be the posterior shoulder capsule. And the last one is going to be the subscapularis. And basically what I'm going to be doing in there is treating the scar tissue directly with my hands. I always talk about getting proper depth and then tension and having the client go through a full range of motion. People say to me, well, this is just like myofascial release. And I say, well, on the surface, it looks like that, but I'm very precise and very focused and get just the right amount of depth and tension to break that area down. So we address the scar tissue in there. And then once the range of motion is as good as it's going to get, here's the thing. A lot of times if there's a labrum problem in there or they're older or there's a supraspinatus problem, we're not going to get up to 100%. We live in this world where we're like, don't live in reality as manual therapists. We think that we're going to get everyone to 100%. We think everything is a soft tissue problem and we look at everything with blinders, but we have to get that range in there first. Once we get that range as stable as it can be, it might not get all the way up here. It might get pretty close to there. That's when we're going to get in and do some of the correctives. And the way I look at my correctives is I want to start to balance strength. So we start very basic. I do some side lying. Once that's good, we go to an overhead press. And if that's good, then eventually we go into an overhead carry where they walk around, really build up more of that overall strength. And then another thing that we need to do is we definitely need to clean up the upper thoracic spine. There's a lot of dysfunction in there. My belief is that a lot of human dysfunction, especially with no trauma, is actually coming from a thoracic spine problem. And when that happens, shoulders kind of roll forward, they go here. So once we clean up the shoulder dysfunction, we need to clean up the thoracic spine function as well. We go over all that in my training courses, the importance of doing all that. So that's really how I manage shoulder impingement. Remember, it's not shoulder impingement. So a couple take homes here. Number one is you got to know what's going on with the client before ever starting treatment. I get so sick of this, like, oh, I'm just going to intuitively feel and go there. No, that's why you're not getting any results, just like everybody else out there. Number two is don't be lazy. Don't fall into these junk box diagnoses. This idea, oh, I got shoulder impingement. No, you should get better and understand you need to get to a tissue specific diagnosis and problem list. And another thing is just ask questions, perform an eval, and be a clinician first, then a technician second. Everyone wants to jump into treatment. I see this all the time in my training modules. They're like, I don't want to do the critical thinking. I just want to jump right in and kind of see how it goes. I'm like, this way you ain't getting no results. You're not using your brain. Use your brain first, your body second. Work smarter, not harder. I think that's all I got for this video. Got any insights, epiphanies, things that might have sparked curiosity in you? Share them in the comment section below. Go grab our free training if you have not done that. I'm always updating that. We have a bunch of different versions of that. I'm always adding stuff, taking stuff away, kind of seeing how it goes. But we really go into like critical thinking, functional based testing, even show you some treatment of the 𝘭𝑠𝑝inatus and things like that. And really just push yourself to think more, treat less, be a clinician, and really start solving problems. Don't just be some random person that just performs a bunch of treatment, throws cups on it, stretches it, does corrective exercises, grinds their elbow in there, and doesn't actually fix any problems. Like, that's why you're not successful. You're all over the place. You got to have a plan, and it starts with a thorough and in-depth history, then a functional based evaluation, then knowing exactly what the problem is. That's how you solve problems, because at the end of the day, the only people that truly get paid are the ones that solve problems. Appreciate you guys watching. We'll see you on the next one. Bye.